All right, let's get started. Good evening, everybody. My name is Hamed with the Stop LAPD Spying Coalition, and welcome to our Tuesday evening webinar. This is the second Tuesday webinar, and typically we hold our general meetings on the third Tuesday, but we kind of switched it. So the War on Youth webinar is going to be next Tuesday, which will be the 18th. Um, and this is webinar number 57. So since March 24th, we've been having a webinar. We may have missed maybe one or two since then, but this is the 57th week that we are on the airwaves. Thank you all very much for joining us and for every week for all these really critical conversations. Just a couple quick housekeeping rules before we get into what we're going to be talking tonight. So because of some stuff that has happened because of Zoom bombing and all, so we are kind of holding off on opening up the mic, but we will open it up in a little bit later, and so people can fully participate. But if you have a comment or a question, there's a raise your hand option in this as well, or just post a question or a comment in chat as well. And the chat is not going to be fully open to everybody, at least for a little while. Again, like I said, that we've had our little bit of share of Zoom bombing as well, but it's going to go to the host, and we'd be happy to receive your messages or your questions as well. So that's just for some housekeeping, and we will be recording it. And this webinar is going to be posted on our website, stoplapdspying.org, hopefully by Saturday. So today we're going to circle back to a conversation which basically got these webinars started in the first place. And the reason being that once COVID hit and it was becoming quite obvious that it's here. It wasn't just like something out yonder or something is may or may not be happening. We switched and pivoted from our weekly in-person meeting at our home in Skid Row at LA Can at the Los Angeles Community Action Network, where we were meeting just as we do on Zoom every Tuesday evening for several years. And we had to pivot, and we switched to this platform. And then we initially had a discussion as to, well, what is a safe platform and this and that and everything else. And Zoom just turned out to be the most convenient because we looked at Mumble, we looked at Jitsi, we looked at several others, and we just wasn't the capacity to have the conversation that we wanted to have that. But today's conversation is really critical. I mean, this is something that if folks remember who were there in the earlier days, that we had invited Professor Vita Amani and other folks from public health sector, and also Jamie, who's also a registered nurse and one of our kick-ass organizer too. We'd invited Professor Dorothy Roberts as well, and some of the folks to talk about the impact of COVID. And since then, what has happened is that the coalition has stayed actively engaged in that process. Actually, there's a whole working group that has developed out of that, led by Professor Amani as well, in partnership with the coalition and the rest of the public health crew. And what we have been doing is this to just to kind of look at the intersection of the national security police state and COVID, looking at it that that typically, and that's what our message has been saying, that whenever there's a crisis, it is times like these that surveillance expands, the military industrial complex goes into full motion, the information gathering starts expanding under the guise of crisis and emergency, and a lot of resources are kind of shifted into that. And in essence, it further tightens the national security police state and the police state that we already live in. But through the year as well, this working group has really been investigating a lot of things. We've been looking how we can better understand the data sharing, the information sharing environment, but really kind of looking at public health with this critical lens of how public health basically is an arm of the stalker state, how public health is central and increasingly expanding in the information sharing environment. There's a lot of concern, and we just don't say that just because, we think that is, But there's evidence to that too, because the players involved in this thing, especially the Department of Defense, the data processing companies like Palantir, and various other arms of the police state are deeply involved in this thing. And for folks who may have heard us talk about Palantir in the past, and we actually did a whole drawing of the Palantir ecology. Palantir, and we'll talk about it later as well. Palantir has numerous contracts, and it's deep into the stalker state, and particularly around just looking at COVID and data collection around the pandemic as well. So it's a vast apparatus, and what the coalition is really has been hoping to do is to really kind of just to investigate the role of these data processing companies, but also to look at that, what do we expect and which direction are we headed in? That how this information sharing environment is further expanding and tightening the controls, of expanding the access to information, and how basically our whole lives and are being bared in this data collection as well. And how it is so, public health is so central to the carceral state, how public health has been historically has been at the center of the white supremacist just goals, and white supremacist expansion and white supremacist governance in the United States as well. So, and in our previous webinars, we've had Professor Amani and Dorothy Roberts and other folks really explain that and walk us through that as history as well. But there's also, the lived experiences of people. And that's where we're going to start off today, is that, people who've been on the front lines, people have seen the ravages of this pandemic, who were providing, the direct services in healing and dealing with people who are being impacted in hospitals and in other forms of healthcare as well. So we're going to get started with that, just to set the tone and move into, and then just to start mapping stuff and share with you. But we want to open it up for this conversation once this initial conversation is done, that collectively, how do we move forward, and what is our fight? And in order to know that, we really need to know our fight as well. But to get started, I'm going to invite my dear comrade and friend Jamie Garcia, who has been on the front lines, of dealing with this pandemic as a registered nurse, and particularly in some of the most vulnerable communities in Los Angeles, in the areas of Boyle Heights. So with that, welcome, Jamie. And if you want to quickly do a brief intro, and just I'll pass it on to you. Thank you.
Hey, everybody. Thank you for that, Hamid, and kind of describing what this group is doing right now, and kind of where we envision where our work is going. It's a small group, and I think that's that's more calming, because a few of us have been talking about, this whole fact that, I was reading a lot of the headlines today and the talk around herd immunity happening in LA County, and, we've moved to the yellow tier. And for some reason, it's almost like kind of unbelievable. And it is, in a lot of ways, as a healthcare provider, in my experience through the surge, has been the bearer of bad news all the time, where you're constantly telling people what they can or can't do, and dealing with, what that means to people. And it means very different things to different people, based on their lived experiences, based on what they are capable of doing, and where they're forced to be and how they're forced to be, whether or not they were able to survive, the surge. And I know right now, we're in a place of kind of safety, in a sense, right now. And I question, as a healthcare provider, what that term really means. And I hope that we can explore what safety really means. We live in a globalized world. We are in the moments of reimagining what public safety means. And so what does that mean, right? And I was thinking today why I've been having such a hard time with all this opening up, and I'm going to kind of take us through a small timeline of what happened during the surge. But I've realized, and I was having a conversation with the educator of some of the nurses at my hospital, and they come in and they educate us on new technologies or new policies and procedures. And she was stating that, pandemic isn't gone. The opening up is really based on the numbers and the ability for the hospitals to hold sick people. So as long as the hospital can hold sick people, they'll open up, right? And when we can't hold sick people anymore and we're in crisis like we were before, they'll shut the hospital. So, and I don't know what herd immunity means in some senses when there's so much movement of people, continual movement of people. And then with the idea of immunization passports starting to delegate, how we can move. For example, I got sent a text that I can get Hollywood Bowl tickets first in line because I'm an essential worker. And they need proof of my vaccination in order for me to get access to those tickets. And I was like, I don't even know if I'm ready to engage in a world like that yet. So a lot of questions for us to start thinking about, because like Hamid is saying, your information and the tracking of where you are and who you are and what like your personal medical information will now start to determine what you're allowed to access. And it has before in different ways, but now we have this other layer. And so one other thing that I was thinking about too, and why I'm kind of still in the state of like kind of feeling like immobile, is because I've realized that COVID is just another thing that Black and brown and poor people will die of. And I've kind of come to terms with the fact that I've seen many people die of diabetes, coronary artery disease, of congestive heart failure, of alcoholism, of skin abscesses secondary to drug abuse and injections. And I realized that nothing has changed, but the understanding that we will now, and when we do, we have a surge unit now at the hospital I work at, which is a separate building that is for COVID patients when we surge again. And so now in my community where, and I call it my community, I've been a nurse there for 12 years, it is now just another thing that this community will have to deal with because the infrastructure hasn't changed. The conversation around healthcare access, resource access, around housing and close quartered housing, around the protection of essential workers, nothing has changed in that, but that we have agreed that certain people are expendable. And we will make space to be able to, house those people if that becomes the issue again. And so yeah. So anyways, so that's it's a lot to think about, and I think a lot of folks are kind of approaching it differently. And I have a lot of questions, as a nurse. But so some things I thought were really interesting so in November 3rd, right? November 3rd was when the surge was called again in LA. And what's interesting is that earlier in the summer and in October, the modeling, right? And we love all this predictive modeling, was already predicting the surge was going to happen. So November 7th, it's declared and they start shutting down. And by the time because I had a slip disc from work, so I was recovering, and then I re-entered work on December 20th. By the time I re-entered on December 20th, we had, and I'm an acute care nurse and there's critical care nurses. So we had acute care nurses that did not have critical care training, starting to move into the realm of taking care of COVID patients. And I'm going to be really cautious on what I say, and I have to always remind myself, because during this whole process, not one hospital reported to county that they were running in crisis, mode, I guess, which means that they were rationing care. I think there's a lot of stories out there from nurses that could dispute that was actually not that wasn't the case, that something should have been reported, Because if something would have been reported, then there would have actually been a committee that had to start talking about who was going to live and who was going to die and who was going to have access to care. So in a lot of ways, the stories that will probably surface in the years to come as we become now, the surge becomes, a study, the nurses were making decisions that were rationing care. When you don't have access to oxygen and you don't have access to high flow equipment, and you are having to kind of engage in kind of pulling things together to keep someone alive until you can access equipment. Those types of stories that are surfacing are what I consider rationing care. So, so that's like around December 20th, right? And so we already knew in the middle of the summer and even October that was going to happen. But during that time, Gavin Newsom signed an emergency declaration stating that, and California had led the kind of way in safe nurse ratios, where we technically, without teeth, were only supposed to be 1 nurse to 4 patients. But during the surge, we were allowed by Gavin Newsom, gave authority to the hospitals to take us up to, I almost believe it was 1 to 12, 1 nurse to 12 patients. Our hospital got to 1 to 7 patients, 1 nurse to 7 patients. And so, and we were wondering as nurses, because, during that time, we were just kind of in a fog and sleeping and working and sleeping and working, how was happening. And finally, the letter was circulated that Gavin Newsom had allowed that kind of surge, that allotment of patient ratio to happen. During that time also, the oxygen shortages started to happen, pipes started to freeze. And like I said, there was lack of equipment. Also, things were happening where hospitals were unable to, what happens when a hospital gets into like capacity, right? I have like about a 300 person bed hospital where I work. Then when you fill or you don't have enough nurses to care for patients, you go on diversion. So at a certain point, hospitals and then hospitals are networked, right? You're not allowed to, like, if I was in Boyle Heights, I'm not allowed to divert to Santa Monica. I have to use the hospitals in my area. And that's all, mandated, right? And so hospitals were trying to divert to each other. And then eventually it got to a point where hospitals were calling internal disasters and being able to shut down. And so there was a few times, I think we remember, where county shut down, the hospital I worked at shut down. But then there was also times when I was on calls where charge nurses in the ER were begging to shut the hospital down and to declare an internal disaster and shut the doors, and they were being denied the ability to do that. So patients were coming. And also paramedics, at this time, lines to get into the hospital got as long as 16 hours to actually get in, and your life was being sustained by receiving oxygen while you were waiting in the ambulance. Experiences that started to surface and stories that started to surface again is that, and we have news articles about this, where paramedics were convincing families and making them make life and death decisions in the home up to whether or not they really wanted to transport their family member to the hospital. And paramedics were being told that if the person didn't look like they were going to live, they weren't to be transported. People whose oxygen saturation, which was the biggest issue around COVID, your normal oxygen saturation is 100%. If you're, little compromised, maybe it's 95. Once you start to get below 94 and you get to about 90, something is critically wrong with you, and you should be going to the hospital to find out what's wrong. People whose oxygen saturations were about 88% were not being encouraged to go to the hospital because life, in a sense, could be sustained at 88%. So overall, it seemed like there was about 19 so far. I think this stat comes from about in the middle of February. There was 19,000 COVID deaths in the county. But from that stat in February 18th, about 12,000 happened during the surge. And then I want to show a map real quick that I just found New York Times to kind of talk now about what in some senses, what I was trying to do during the surge was I was trying to find out why we couldn't divert to like Santa Monica, why we couldn't divert to other cities because they were not being hit as hard. I was speaking to a friend whose wife was an ICU nurse on the West Side, and they did not even get close to the numbers that we got. And so they were not allowing us to divert until January 7th. Were they allowing North or Southern California to start to divert to, or Southern California to divert to Northern California. But to put that into context, by January 25th, we were reopened for outdoor dining. So 13 days before reopening for outdoor dining, they finally started to allow us to divert patients. So when you think about that, November 2nd was when the surge happened, right? And so I'm sorry, I'm like kind of everywhere. And there was a prediction, there was modeling that this was going to happen. Something else that was going on in the hospital when I was talking about those emergency ratios, they finally hired staff, and staff probably came in right during the same time around January 7th. And they hired travel nurses to come in. And by the time they were trained and they were helping, probably 2 weeks later, we were finally at a capacity where we could handle what was going on. And then nurses started to get canceled and were not able to work because we were mandated to give the traveling nurses hours over our hours. So nurses actually started to not get paid after the surge. So to put this into context, right, when we think about why I'm kind of like hesitant about all this, reopening the celebration, is because I realize nothing has really changed. It's just now I have to realize that my people that are in East LA, siblings in South Central, now have to just deal with COVID, right? And maybe we have this herd immunity, and maybe this will last. I don't know, but it's just something that's going to happen. And for everybody that survived, now we'll figure out what long hauler syndromes are and what will come up after that. But on this map, you can see that it got so bad when you get down to East LA, 1 in 5 people had COVID, 300 died. In Boyle Heights, 213 deaths, 1 in 5 people had it. You skip on over to Santa Monica, here's Brentwood, 1 in 24 people had it, 9 people died in that community. Here, there was 1 in 32 people had it in the Palisades, and there was 1 death. You drop down to where MLK Community Hospital, who actually, and let me see, where exactly?
Jamie, just real fast, are you trying to show us this image?
Yeah, you can't see it?
I can't see it. Can you all see it?
Oh.
Wait, the
Yeah.
pop-up of number of cases and deaths?
Okay, never mind. It's just me.
Okay.
Sorry, yeah, cases and deaths and share of population.
Can you see the over, like it's highlighting and popping up Willowbrook? Yeah, okay.
Yes.
So it shows 1 in 6 people in Willowbrook had it, and there was 57 deaths. 177 people died in Linwood, 1 in 6 people had it. So essentially, and I'll just leave this map up a little bit so that you can see, like the purple obviously is the density of who was dying the most. And for folks who know Pacoima and Silmar, those are like my old hood with my family, hit really hard. El Monte, West Covina, mostly Latino neighborhoods hit really hard. Pomona as well. So West Hollywood, Malibu, Playa del Rey, actually their numbers dropped during the surge. They have $2 million homes there, vast recreational open spaces. Economically, their jobs allowed them to be able to stay at home. And they're and on the east side and eastern San Fernando Valley, south central, southeastern parts of the county, you have overcrowded conditions, and essentially you have essential workers. And so that's pretty much why people died. You know, nothing has really changed. I think pre-pandemic, I watched people die of, you know, diabetes, you know, heart disease, sent people home on charity meds for 30 days, knowing they would come back because they just had no access to those resources. So it wasn't a surprise that folks in that community not only were more susceptible to getting COVID because of their jobs, because of the close housing, but that they were going to die when they got COVID. But also that the healthcare systems that were in place there were not going to be able to sustain the surges that happened in those areas, because they weren't even able to sustain what was normally happening. I had already worked during times pre-pandemic where we called internal disasters in the hospital. Being involved in an internal disaster in a hospital, closing our doors, was not something that I experienced because of the pandemic. I had experienced it before. It's just that at this time, I was naive to question why more help wasn't coming. And I think that's my biggest lesson, is that it was the naivety of actually thinking someone was going to come help that caused probably more trauma. If I would have just gone in knowing that the intent to cause harm and the intent to for the community to die had always been there. So I don't know. That's where nurses are at right now. We're trying to celebrate with everybody. I know there's like a breath of relief, and it's allowing me to have space with my feelings now and what happened, and everybody is kind of, you know, feeling safer. So, you know, I congratulate us all that are being able to visit family and being able to visit friends and being able to, you know, share space and hold space again. But I encourage us to keep unpacking the medical apartheid that caused so many of our Black and brown community members, our poor community members, to die and to suffer unnecessarily during this surge.
Thank you, Jamie. Those, yeah, I mean, I remember those months as well, and the intensity of the surge and where we were. So with that, I'm going to invite now Professor Bita Amani and Consuela and Mina and Brianne to take us from there. And yeah, so I'm going to pass it on to you, Bita.
Can you all hear me?
Yes.
And can you see the shared screen?
Yes.
Yes.
Yeah, okay. So, you know, actually, I'm gonna stop this, and I want to give a little bit of context about how this presentation came about and the significance of us thinking about doing this work right now in this moment with, you know, as Jamie is describing, something is different here in California, right? Like we literally have different lights, you know, like, or, you know, we're, you know, I'm sorry, in different tiers, right? We're not in the red tier, you know, people are experiencing some sort of like turning a corner. But yet, if we were supposed to have learned anything from this pandemic, it's that if there is something going on in one place in the world, it's going on right here, right? In your neighborhood, in your community. So you continuously need to be vigilant, and you continuously need to be being critical of what Jamie's calling the medical apartheid. But then, you know, more broadly, what the role of science, health, medicine are in the maintenance of white supremacy, the building of empire, you know, and continuing, you know, settler colonial domination. You know, what is happening in India right now, what is happening to the Palestinians is extremely relevant to this conversation. And at our last work group meeting, when we were thinking about the ideas to bring and to present today, you know, we had been building up to that, and then reviewing the internationalism in our work, how we have completely been connecting local fights for reimagining and abolition to the global conversations on death, war, disability management. And so, you know, bringing them together today, like I really hope that we can all continue to have that conversation that talks about it locally and, you know, continues to like bring in the international. So in February, before the pandemic, you know, was officially, before it was officially declared a pandemic by the WHO, right? You know, pandemic was already, you know, in the making, if not here. We had been working on addressing the problem that we have within abolition movements on how we want to push for decarceration and more community-based care, but how integral public health, science, and medicine is to community-based care. And we know that these are also extensions of the state, and they do state work, and they've done them historically, and they will continue to do so. So what does it mean then to like close down prisons and jails and then imprison people in substance abuse centers, right? Or like, you know, and that while we are like advocating for community mental health, right? Community mental health centers, we knew for those of us within the profession that we were lacking in the knowledge and the infrastructure to really be able to like deliver on this promise that we are hoping can be like a major, you know, like argument, right? For us, like, you know, moving away from moving away from institutions that are so carceral, because what we're offering up also is built on and based on carceral logics, right? So in February, when we were thinking about this and the role of surveillance and technology, we had proposed to the American Public Health Association, which is like the leading kind of national conference body, right, of our, you know, of us as professionals. And I'm looking at my public health folks to clarify, because, you know, it means so many different things to different people, and I actually don't know officially what it's supposed to do, but, you know, it's the place where we, you know, we say, hey, we're going to come and be collegial and see what new ideas are out there and really represent and push for the ideas that we think are the most important. It's organized with many different caucuses. And so for the Peace Caucus, which historically is a very important caucus, very relevant to the work that we do here, we put forward this project that I'm about to show a summary of right now. And this Peace Caucus has taken the position and really held down within the public health world space, right? The idea that militarism and science and medicine and public health have always been like intertwined, and that if public health doesn't take on an active anti-war stance, then like, what does it even mean when it says the word equity? What does it even mean when it says international health? So is it maintaining international health for the purpose of allowing for goods to move across countries and borders, so that the WHO then just supports the United Nations in making sure that countries are stable enough, like in quotations, so that manufacturing, production, and extraction, right? And all this stuff can continuously be maintained. It really keeps in its center the idea of the role the scientists have played in the Manhattan Project, right? And the idea of atomic warfare, landmines, right? Like that this is all science, this is scientists, right? These are doctors, these are physicians, these are, you know, public health professionals that are actively working to develop these technologies, right? And then when we push for example, all across, right, the United States, we know how we have an underrepresentation of Black and Brown students in the health sciences. When we push for STEM education, science, technology, engineering, and medicine, when we push for them, we're also pushing for military, right? Like support and entrenchment into like in the service of US empire. And so the Peace Caucus has always held central to that. And so what we wanted to bring to it was, you know, the conversations on police violence, on abolition, on thinking about then specifically the fact that public health is not something that we cannot sit here from a perspective and say, well, there's a magnanimous public health, there's a public health that's kind, and then there's a public health that can be used for evil. That we have to understand that public health is what has helped empire build and amass its power, right? For over 500 years. like the very root of the word statistics, like this is derived from the idea that numbers are for the state, right? That the numbers are for the politician so that they can manage the political order. And as we've seen over the last 14 months, there's a growing racial consciousness of what is race and racism, right? You know, to this political order. And what has that meant then for, as Jamie is saying, the emergence of new diseases, right? The management of new diseases, and now the management of the disability that comes from these diseases. And us coming to terms with, if public health is directly for the state, and it's if public health is directly, if public health is a tool of the state and is always necessary for state building and for doing empire's work, then what do we think is possible around reimagining a new world when we know that we want to manage death, right? We want to prevent death, and we want to prevent illness and death, right? And then if we're in a position where we have these conditions, we also need the tools and technologies because we want better outcomes for ourselves, right? So that we sit at this kind of crossroads. Then the pandemic hit. We were wanting to do this work for the Public Health Association. Brianne came to work with us through really wanting to understand more about the role of structural violence, carcerality, and technologies. And she was a key researcher for this project. I'm gonna review very quickly today, a lot of which the information you all already know. Mina came to partner in this work as a member of the COVID-19 Racism and Equity Task Force between CDU and UCLA Center for the Study of Racism, Social Justice, and Health. She's a postdoc, and if she's able to share later on, she can provide a fuller introduction. But Mina really came to this wanting to talk about the role of the international, coming to appreciate and learn from the coalition, and to question how is it that as somebody who has a PhD, is a postdoctoral scholar, in this work, we don't talk enough about the direct harm that surveillance is causing on communities, and what that means then for the things that we push, and how we are then always in these traps of reform, right? That we can never escape these reform traps because this is our profession, and we're also not aware of these other things. And Consuela also comes to work with us through the task force. Consuela has been already a graduate with her MPH in environmental sciences. She came to really doing a lot of our work on what's going on with all these testing facilities. How do they open up? How do they close? What does that mean for the numbers? What is going on every week in terms of the international state, right? The international state of COVID. And if she's able to share later on, she will also give us, more of this context. So we all came together as a team with Stop LAPD Spying to bring the fight that's local to the fight that's international, and for us to center in the middle of it the fact that we cannot afford to have any more delusions about the discipline and about what it does, because we need to get to the next part, as Hamid says, of knowing our fight, right? What are we going to do? If I had to fast forward to any endpoint here, it is that in the same ways that the states, for example, the Israeli state pushed for vaccination of its people. It's got the highest vaccination rate in the world. I think close to 60%, right, of its people are vaccinated. The vaccines that it gives to the Palestinians, or the Palestinians that are going to cross the checkpoints to come and work for the Israelis, right? Those are the prioritized populations. I think its vaccination rate is also 60 times greater, right? Than the Palestinians, right? So if in the same ways that these technologies we see right now going live are keeping people healthy enough so that they can continue these projects of domination and supremacy, right? We also have the example of Cuba, right? Where a country is producing vaccines and sending people all across the world because public health as an essential part of that state is an essential part of liberation for the people. Right? So that we then have to see these examples internationally. We have to compare the way that our technologies that come from our bodies, literally, because they're made with our, with our participation in clinical trials, so on and so forth, right? They come from us. How do we also take advantage of these to be able to move ourselves further? But we have to be really clear about this thing that we're negotiating with, and who and what it is. So if I were to share right now this, and we can make it available because, and I don't want to go through it in too much detail because I know many of you know the points that are already in it. But we were there to essentially, for a public health audience, complicate their understandings of structural violence by helping them reconceptualize the relationships they have had with the health sciences. This is something we ended with, but we'll start with here today. A framework for integrating these things is to, one, appreciate that racism and racial logic is embedded throughout all systems, structures, and institutions. That the racially structured inequalities manifest health disparities. It is racism, right, that is producing the conditions that we see today. The patients in Jamie's hospital have been put there by structural racism, right, and structural violence. That local and global racial oppressions are connected. This is an intentional system. The health sciences are not the answer. We are one tool, right? So when we're thinking about this local abolition fight and community-based solutions, and then, let's get them into medicine and care, right? We are not the answer. And knowing all of that, then it gets to the idea of reform and critically interrogating the solutions. We took the audience through just, things that seemed more relevant to them here. Oh, this presentation was in November, by the way, around like policing and carcerality, gave them a sense and scope of the problem, connected it to local fights, like, for example, through organizations like LA Can or YJC, talking about the central role of policing to like stealing of lands and displacement, right? And the management of displacement. And that even if you are having wins, like we are seeing in youth diversion, you can still see structural racism because, for example, if we think about youth diversion here in LA County, it primarily benefits like white youth over Black and brown youth. And then we were moving them into appreciating like just the scope and scale of empire, right? I have a statistic here. Let me pull it up. That there are nearly 800 military bases in more than 70 countries and territories abroad, right? So this is not, this is the scope and scale of it is unlike anything that's ever been seen on this earth. So when people want to say, oh, we had the Roman Empire, we had this empire, it's like, what are you talking about? Like, scope and scale matter here, right? Like, whenever we're hearing the arguments come out of, India, well, how many people are dying like per 100,000? It's like, how many people are dying, right? Like, in India. And then also the fact that, like, as this top book is alluding to, like security and terror, or not alluding to, but talking about directly, that all of this has been about projects of manifest destiny and securing what is stolen, and allowing and creating the set of conditions for more to be stolen, right? We had to do the fast talk on this. And then, just connecting it all, connecting the racisms, right? Connecting anti-Black racism to anti-indigeneity to anti-Muslim racism, thinking about what's happening on the border, right? And the migration and the detention centers. So who is the criminal illegal terrorist? As the coalition always says, like, we're in, the ways that we're in this fight, together. Even though we recognize that it does not have the same effect and impact, right, everywhere in the world. If we think about specifically anti-Black racism and police violence here in the United States, and that empire structures global states of death and disability management in the production of the arms, production of prisons, detention centers, bases, pharmaceuticals, biomedical technologies, illicit drugs, extractive production energy, and the final point, which is extremely important, the demand for rehabilitation, right? Whenever we see prosthetics that are out there and we are like, this is amazing, right? It is a technology that is also the answer to the amputations that Jamie has to, right? To coordinate, and participate in the care management of, right? It is also a part of, like, it is also the solution to the soldier that loses their leg or their arm, right, in Iraq and Afghanistan, having killed somebody else. So the demand for rehabilitation is part of this. And so then, just connecting this, structural violence, it's framed as a systemic failure of empire. This is a big problem in public health, right? We think that we can do violence prevention work. We think we can come out here and we can like describe the different types of violences, who's being killed by a gun, who's being killed by a knife, right? Who's committing, who's being bullied. We can just make categories for all these things, figure out who the people are that are in it, because it's a failure of ours versus seeing that it's something that we've made. And then we took people through just medicalization and contextualized it in so many different ways, locally and globally. Contagious divides, particularly like useful to the coalition's work around mapping, right? And the ways that mapping was specifically used to police and manage Chinatown in San Francisco. Healing the Land and the Nation, is about the Zionist project to do vector control around malaria, right? To build a healthy, right? Like in quotations, a healthy, like Israeli state. Then, we talked about things that, you all are extremely familiar with, people who've actually come out and, have spoken with the coalition, built and organized with you all, Virginia Eubanks's work, Ruha Benjamin, Simone Brown, and that, just then locating all of that within, once again, like, the larger global struggle for freedom, and the people that have, drawn our attention to, that violence has always been used against us, right? Violence, just like public health, is a tool of the state, and it's not something that we can, sanitize by medicalizing. But that, internationalism, and specifically medical internationalism, so another way of doing health, has always existed. And then this was the framework. And then these were just questions that we're posing to our own, to the next generation of scholars, and ways on trying to get us to think more critically about how we've come to produce our knowledge. And then we just highlighted key movements, right? Statewide, that, we support the visions that they're trying to bring about. So that was, that presentation. I'm going to stop here, and I would love it if Brianne, who, worked on the project as, one of the main, gatherers of the information and helping to take it from something that was so huge into something that was very visually pretty. If she could, just talk about what all that meant for her, also being an MPH student at this time.
Yes, thank you, Dr. Rani. So I think something that's really important to take away from that project is like two things. One being the importance of like critically interrogating the solutions that are proposed. We accept these like techno-scientific solutions because we accept that they're the only solution because other efforts aren't going to be made to address the problem. So, we accept these vaccine passports and contact tracing because we've accepted that, there's not going to be anything done to address housing and giving people paid sick days and guaranteed income. And so then we accept these solutions and they seem like the only option. And so I think that's an important takeaway of always critically interrogating these solutions that are proposed. And the other thing being that structural violence is framed as a systemic failure, as opposed to like an intentional tool. Like in that way, also that public health, using public health and the health sciences in a way that is colonial and white supremacist is viewed as a failure or an abuse of public health rather than the original intent and design of public health. That public health was designed to ensure empire had access to trade and our ecological or economical interests, and that it wasn't designed with the public in mind, that it was for security and that it was for economy. And so thinking that it's not the abuse of public health, but that was the design of public health, and that the structural violence that we see is not a anomaly, but it is the design. I think are the two most important takeaways from that project to me. Do you want me to show the vaccine passport document, or do we want to go to Palantir?
Oh, quickly before we move on, I just want to say that I agree with everything Brianne said. I think public health is going through a very interesting transition, especially with an incoming large generation of public health professionals that are making the older public health professionals very uncomfortable with really taking accountability for the infrastructure of public health, right? And so I think as we kind of move forward with this project, or just in general, I really challenge not just public health professionals, but just everyone to really understand their role in anything that we push forward, right? Where we really critically analyze the solutions that we put forth and understand who they're advantaging or even disadvantaging. But yeah, I don't even know if those are words, but y'all know what I mean. But yeah.
I don't know if we have time now. Maybe I can come back when we have open it up for the discussion, but I was really curious to know about what the audience's reactions were, and even what the group here thinks about, the health sciences not being the answer, and how, were they receptive to that, and how was that conversation? Where did that lead in terms of proposing alternative solutions? Because, my kind of assumption would be that most, that would be just totally mind-boggling to most public health professionals, right? So that was just something that I was curious about.
I think something that Jamie was talking about earlier about all our modelings were predicting that there was going to be this surge, and what did we do? So how is the techno-scientific solution of modeling and data solve anything if then the surge ended up happening and we did nothing to change it? That wasn't the solution. The solution was paying people to stay home and closing down non-essential businesses and housing people. But the solution instead was data and monitoring data and collecting data. And what did that data do? What did it solve? We had the surge anyways. Yeah.
I think that's such a great point, because this is not the first pandemic that we've had, right? And it surely won't be the last, right? And so the excuse is almost that every time we have a pandemic, we've learned something new, and our processing becomes better, but we are still in the situation that we would have been in regardless, you know what I'm saying? And so it really highlights and just shines a light into this dark hole of what are we attempting really truly to do? And if it's not for the protection of people of this world, then what is it really for? So.
And I think that's a unique contribution that this coalition is making. And then also the task force that Dr. Amani is co-chairing is really employing this historical framework, right? So recognizing that exactly what you said, Consuela, and that it's really not conventional in our training to have a historical framework, and then we don't learn from, we keep repeating the same mistakes. And then also the fact that something that Dr. Amani is really leading is having this equity lens within the context of a public health disaster. That kind of narrative and those kind of strategies are really not mainstream in our training, in our discipline, and in our strategies. So having that kind of historical equity lens are both lacking. as well as the very like strong and critical need to put the community's voices and experiences at the forefront of not only recognizing what their needs are, but how to adequately address them. So those are all really unique contributions that the task force and this coalition is doing.
So quickly, this is really nice. I really appreciate this in a very organic way. The way this conversation is taking shape. Because I just wanted to, before we lose it, because we're talking about data, and there's a couple of questions were raised in chat. So I just want to, before just to hit them. So one of the questions was, Jamie, about when you were showing that piece around the New York Times mapping of this thing, that whether I mean, in a sense, talking about data, that communities which are now being shown as being the most hard hit, typically but the question is that that these spaces and communities are underrepresented in normal times anyways, right? So then, I mean, how are we to look at these numbers, that whether they are even providing us the real story or not? And so that's just in the sense of how politicized these things get. So do you have any thoughts about that?
Mhm. Yeah, I mean, it's probably even more, right? And I think that, as far as like tallying why people were dying, is another question too, because was everybody marked as a COVID death? There was, stories, also news stories circulating that people in Skid Row were dying of heart attacks or, found dead in the streets. And if you were not tested, then you were not counted as a COVID death, right? So you needed to have access to testing to be able to quantify you as that, so that they could actually say that's, why you died. During that time, did they count everybody? I'm assuming they did. Were there trucks and trucks of bodies being loaded up into trucks? Yes, that was happening. And I mean, I know for myself, in the phone calls that are starting now and the questioning that's starting now, like I can't even believe, what is it called? CMS, what is their acronym? California Medical System. I don't know. They're like one of the people that come in and audit you. They're auditing us now, right? So I find that part, the punitive part of it now is mind-boggling, right? So we go through this, we don't get any resources, and now they're coming for us, right? And now, like, your name is all on these charts and investigations are happening now, right? So it's like you're a hero one day and you're in a lawsuit the next day. And I think about how the hospital didn't declare that they were operating or rationing, care. And, so then it makes me wonder, what is going to happen in, like, a lawsuit, if people, because we're not, most people are trained to use the legal system to find a remedy or to, like, find some kind of like change, right? So they think maybe by suing the hospital or, doing that legal route, some kind of like remedy will happen, where, like, what I feel like we really need is like a full movement to identify that structurally this was destined to happen. This is how they wanted it to roll out. That the East Side was not, or I'm sorry, the West Side was not going to tolerate any of that. And they have never tolerated any kind of like malpractice or lack of resource or lack of what they need to be healthy. It was always the case that people on the East Side and in South Central were subjected to, menial existence. And so, yeah, I don't know if the numbers really matter, because how much more data do we
Right.
need? Okay. Sorry.
No. Finish. I was agreeing with you. So
Okay.
finish your thoughts.
Yeah. So, like, how much more data do we need to prove the point? Yeah, maybe there was some miscalculations there. That definitely could be the case. But, you can go back 10, 20 years and find, you know, another type of disorder like diabetes or CHF or, you know, and look at see the same kind of statistics. You know, you'll see who's the hardest hit from it.
Mm-hmm. Which
I
then
think
sort of, I'm sorry, go ahead, Consuela, because I was going to lead
no.
into the second question, but go ahead.
Oh, no, I was just going to say, Jamie brought up a good point in regards to access, but not just access to like testing. A majority of Black and Brown individuals were individuals that were considered essential workers, right? So if I have to decide between taking a test to say that I'm COVID or putting a meal on my table during a time where everything is shut down, what am I going to choose, right? And so I think those numbers really only tell a portion of the story. I think if you take those numbers with a grain of salt, right, there are probably large amounts of people that kind of, I hate saying the word, like sucked it up and went to work, but had to, right? In regards to being able to provide for themselves and their family and just didn't get tested, right? Made that conscious choice that, well, if testing puts me out of work and I'm not going to get paid, right? Like this is what I have to do to make ends meet in a time where everything was shut down, right? A lot of Black and Brown don't have the ability to make that choice and be like, oh, well, I can take, you know, I don't know, 3 months off of work and I know where my bills are going to be paid, right? Like food is going to be put on the table, so on and so forth. So I think access in a variety of different ways really speaks to maybe a portion of those numbers, right? But I think it really doesn't tell the whole picture.
Mm-hmm. That's very well put, because it sort of perfectly segues into the other question as well about the politicization of both the structures and concepts as well, where, you know, it's more of a comment that I'm reading that public health is a scare tactic by government media. So, and I guess maybe we can build on that too, because as you all are like, you know, so the idea being that it's public health. So what is public unhealth, or the lack of, or the unhealthy one? So as you were speaking about it, Consuela, I was thinking about that it's not just not just only about putting food on the table, but then you're permanently marked as well. You become that other, you become that permanently marked, you become that stigma is attached to as well, that you are that sick body. And then, you know, your sick body is going to just like, you know, just create more sickness to the other bodies that have to work and all of that too. So yeah, so I just wanted to kind of see if you all have any thoughts about, like, you know, public health as a scare tactic, asking the public health group.
Oh, honey, okay, I don't want to talk too much, but I was just going to say, I think that also like speaks to, we didn't even touch on like the extreme long history of just like healthcare being like used against Black and Brown people. And so like, that just brings up like a whole different, like, you know, like the pool of just madness, right? That also feeds into, you know, what is public health? Like that is really is a question. Like, is it really being used again for like the betterment of people, or is it not? And so, yeah, that's just a whole other thing as well. Mm-hmm.
Thank you. So I think continuing on with that, Beta, so I guess I'll just pass it back on to you.
I have a hard time answering this because I know how much has happened, like always happens in LA, all over the world, to use issues of hygiene, to come into quarantine, to isolate, to take, if we think about what's happened to unhoused communities, just like every year, right? Every year something comes up, a hepatitis, right? A typhus, like that, something requires to be confiscated, and there's a scare that's wanting to be generated. And, you know, I know that in the past, LA Can, for example, has even brought out DPH folks to be like, hey, like, this is not, like, relax, like, it's not a big deal, because of the ways that it will be used. I think I'm having a hard time though right now, even though we recognize and we know that that happens, that will continue to happen, with the way that public health is having to play the role to say everything's okay. You know, like, let's all get in line and in order for the economy. You know, like that, all of that right now is, you know, kind of where you just wanting to like wait to see what the science, you know, is saying, and just wondering why, like, you know, if we were really are caring about the experiences that Jamie talked about and the impact it had, Like if that was, truly a desire, then, and we see what's happening in India, and we see what's happening, right? Like in like Nepal and Sri Lanka and Ghana, right? We see in Brazil, like we see that in neoliberal, like economies, like COVID looks, very clear way that the essential Black and brown workforce is going to go. And in the process of them going, they will take down the healthcare institutions with them. So the hospitals will not be available for any and everyone else, right? Like we've seen enough of these like what we're calling surges play out, and we're seeing this happen right now on larger scales globally. So then why not be a little safer? Why not say, hey, it's a priority for LAUSD to open because the children can really benefit from it, and Hollywood Bowl, like, you don't need to open, right? We don't need, like, that doesn't need to happen. Like, why not? And then the answer then becomes, and getting back to this comment, because there's no political will. There's no political will to think about the populations and the people that need to be cared for. So how do you mobilize and pull the resources of the state to take care of those people? Because you value who and what they are for, the economy. So if you do treat people, if you do think of people as being disposable, you can both weaponize, I guess, public health, like in the sense of like making it really scary, like what could happen to get people to do what you need them to do, or to buy into things that you say they need. Or you can do the opposite, which is to have them forget that they need something, have them forget that they need you to, take a hit and say, you know what, we might be wrong, but Hollywood Bowl, you can't open, right? And like, and let's just go, and let's go a little slower. That doesn't mean we have to be in how we were. Dude, we haven't even brought up the fact that there was no toilet paper, right? Like on shelves, right? Like, we don't have to be like that, but we can be a little bit more conservative, because we know that if there's a problem anywhere, there's also a problem right here, right? And that we want to even maybe take a little bit more risk for ourselves to share what we have with someplace else. Like if California is in a place where it can maintain what it has, but it could share its vaccine and resources with India, for example, right? Assuming that would even be like, it would be helpful, and that needs to be thought through. But like, why not? Why not think about these things? And then it gets back to, because it doesn't make sense for the economic health, and it doesn't make sense for US like security interests, right? And not just US security interests. If we think about, if we think about Israel, and we think about other places as well.
Nice. Go ahead, Mina. You were going to make a comment?
No, I was gonna pose another question, but I can wait till, let's get through other people's questions first.
Well, I'm just opening it up. If other folks have any questions or comments, and actually, I think what I'll do is just, folks can unmute themselves and they ask a question. So please feel free. But go ahead, Mina. And then because we want to go into the data sharing and all of that too. So go ahead.
Right. So this is kind of related to that. I was curious to know if Jamie could speak on this at all from the clinical perspective. But something that Dr. Amani made me aware of just yesterday was the fact that there are various changes being proposed to HIPAA. And when I tried to learn more about that, these recent proposals that I'd never heard of, and the period for public comment has now closed as of last week. I then learned how within the COVID context, a lot of restrictions or enforcements of HIPAA have been eased within the COVID context. And I was curious to know if you witnessed or experienced any of that within the clinical setting. And I mean, this is all relevant for data sharing and how, going back to the kind of central core themes that were introduced at the beginning of the talk, how public health is not just, complicit, but like an arm to the police state, and the weaponization of data, and, the whole data sharing apparatus of the stalker state. I was really concerned to hear about, first of all, that this was happening, but second of all, how this has not been widely discussed, let alone responded to within the public health disciplines, but even just trying to find like easy to interpret like information on what exactly they're changing has been really difficult. So of course, this has a lot of implications for our communities, and in terms of community safety and protection and health and well-being. And this is something that I would love to, put forth to the coalition, if this is something we can be more, mindful and aware of, and to monitor, to first of all see what changes are being made, and then to really critically analyze the implications this has for communities, and then to provide that much needed political education, so that communities can be equipped to protect themselves as best as they can. But so from my understanding, and the language is incredibly vague, but these proposals have all been kind of set forth because of concerns to ease administrative requirements and reduce administrative burdens that HIPAA places on covered entities. And again, who these HIPAA covered entities are is unclear. And yeah, I was just sorry, curious to know if you could, if you've experienced any of this, and if you could talk about this from the kind of clinical perspective.
Yeah, I mean, that's a very interesting question, because I won't ever disclose if I ever violated HIPAA because I'd lose my license. But I will talk about situations that that were emerging on a very practical sense, and not to disclose anything. But imagine that your loved one is in the hospital, and doctors, that I'd be seeing would have up to 60, 70 patients on their roster that they were servicing in one day, trying to keep people alive. And you're trying to find out what's going on. And we technically cannot disclose information over the phone to a family member. So was HIPAA violations happening? So that's one way in the COVID context. How was HIPAA? How were potentialities of the various nurses you could talk to who, possibly violated HIPAA in order for communications to occur? The only way I could put this into context, and honestly, it doesn't have anything to do with, anything clinical, because what we're doing is basically like documenting, and people are not coming in and engaging with us like about information and whatever. It was more like families maybe over the phone saying stuff, maybe texting a doctor, those kinds of day-to-day HIPAA violations that could possibly occur in hospitals. I imagine were happening. But one thing that I've been looking into a lot, particularly because of the coalition's work, is starting to look at genomic surveillance. And genomic surveillance is, where they're basically trying to code all the variants to monitor where variants are popping up in various populations. They want to be able to monitor not only the variant, but they want to be able to monitor what is the end result of the type of vaccine you received and its response to the variant. What is happening to you 3 months out, 4 months out, 5 months out, and 6 months out. And so this is something that the group talked about, I think about a month ago. We kind of raised it, where the conversation started to be raised by this person, and what is his name again? Hold on, I just brought up the article too. And it was an MIT technology review, and it was based on how Joe Biden basically wants, sequencing of 5% of all COVID cases to start to track variants. And this guy from the CDC's Office of Advanced Molecular Detection, Duncan McCannell, right? He basically posed the question that if we move in a way where most data that I guess public health works with is de-identified, right? So your name, your location, it's like your gender and your age, and everything else that can geolocate you is taken out, right? Because, and maybe it's just kind of like okay, they're in LA County somewhere, or they're in Southern California, but they can't get down to who you are, what neighborhood you live in, where your house is at, what hospital you went to, what's your follow-up looking like, what is the outcome, what kind of vaccination did you have, what is the outcome of your exposure because you came down with this variant, what happened to you? So he was posing that question like, we don't know what's happening with these vaccines. We don't know if these vaccines are working. So we need to re-identify the data so we can track people and we can track what's happening with the vaccine. And so this goes back to the techno-solutionism and the what we're forced into. And granted, I am getting my booster. I am getting vaccinated, right? But like I said, I'm not ready to go to the Hollywood Bowl and show them my vaccine card. I don't know where I want to participate in this new world that is evolving in front of us, because now the discussion is happening. And I am very unsurprised that this HIPAA thing came up, because it's lock in step with the fact that the CDC didn't mandate that, okay, or didn't take a position on it, right? But that they posed it into the environment, like, well, you know, if we had more data on this person and found out what happened to them, and we knew what neighborhood they were in, and we knew what kind of vaccine we got, and we knew everything about their medical history after that, then we could really know what would happen if you got that particular variant and you were vaccinated. So it is not a surprise that this all of a sudden happened. And I saw that pop up, and I haven't looked more into it, but that is what genomic surveillance is talking about. Not so much, you know, yes, they're getting the genomic sequence of the variant, and yeah, they're getting access to all your HIPAA, but and then what's happening too is it's globally happening, right? So not only is it nationally happening, it's happening on a localized level. It's happening nationally, it's happening globally. And the push, and that became part of the package, the couple $1 trillion package or $1 trillion package that Biden pushed through, was to give public health the ability to do the sequencing. So that's the only thing it really makes me think of, because when you work with de-identified data, you can't, like, there's only so much, and he speaks about it in this article, that it's a 10,000 foot view you're getting, where if you got identified data, you would know exactly what happens to that person.
So I wanted to just quickly share, and want to go to Brianne and Consuelo to talk about immunity passports. And I was, this was just a very baseline stuff that we had for the stalker state purposes. We had kind of mapped out around, you know, just Health and Human Services information sharing. And this is just a very rough sketch of that too, and goes back to, you know, I mean, how under the Patriot Act and everything else, like, you know, so under the guise of national security, I mean, HIPAA is set aside. I mean, most of the time it is set aside for investigations for national security, and how, you know, warrants and various other things. So, and how information is gathered through the various electronic information sharing and stuff. So yeah, I mean, that becomes really a critical point. So maybe just moving on to, so whoever, Consuela, Brianne, however you all want to just roll with that. So we want to talk more about Palantir data sharing, and also the issue of immunity passports, and where are we at with that? So whoever wants to go first.
I can touch a little bit on Palantir. So I think it kind of actually flows like perfectly with what's being stated in regards to like just data sharing. So while we've been working with this group and the coalition, I think a question that came up was just like data sharing. And so we decided to look kind of into Palantir. I think there's like a lot of like whispers occurring about just kind of the contracts that Palantir had with the government. And Brianne did a lot of the legwork in regards to like digging into what Palantir was doing. And what we found was not much, but I think what we didn't find was pretty telling. And so what we found was that Palantir has like multiple contracts with the government through different agencies. And what it seems like is it's kind of been a shift in regards to how much freedom that they're getting with COVID data, where it had originally kind of started with assistance in regards to kind of this huge lack of just not even material, but just like machinery in regards to like, what hospitals didn't have, and kind of like a mainstreaming of just like resources for the nation, and has kind of moved into a new contract where they are essentially what they call like a unified system for healthcare is what they call it, with like the federal agencies. So essentially, it's bringing up a lot of question in regards to what. Let me go back. So the question that originally started was all of this testing data, vaccine data, where is it going, right? What we found, especially with California, was that there was a lot of entities kind of like moving, right? Community centers were providing testing, hospitals were providing testing, but who do you report to? How quickly do you have to report? Really couldn't find the answer, right? Like different guidelines were kind of put into place for like different, it was just a whole hot mess, right? And so this looks like this contract with Palantir with a government looks like an attempt to like unify all of these like different guidelines that are happening, not just at a national level, but very like local. And so in regards to like all of this like data collection, what we see is that Palantir is supposed to be kind of creating like a unified like healthcare system for the nation for all data information, but we don't know what that looks like. So does that include all of just COVID vaccine data? Is any of your genomic data also going to be put in place? And you don't even know, right? These contracts are kind of occurring. I think that also plays into like this HIPAA situation as well, where there has been this like leniency. So is this playing into like Palantir getting a lot of access to data that you thought that you're only giving to your like hospital, but is really going into like this like government agency? So that's kind of like the overall gist. But they've gotten hundreds of millions of dollars in contracts, but we don't know what the contracts are for. And so like when you go on to like government websites, they're very like general descriptions of what they are kind of being contracted to do, but we don't know. And so I think it kind of works hand in hand with kind of the conversations that have been occurring with just about our data and like what that means. But yeah, that's kind of like the overall gist. Brianna, you could definitely add a lot more to that, but yeah.
I guess less about Palantir and more just about other like government and private sector like cooperations, I guess, for like techno-scientific like solutions. Let me share my screen. Something else that we were looking at was these vaccine passports that are, starting to gain attraction and energy around. And so currently the Biden administration has said that they are not going to do any federal vaccine passports, but they hosted this webinar discussion to collect all the different organizations that are putting forth these vaccine passport efforts to come up with a centralized response and a unified like effort. And they wanted everyone to work towards the same common goals. They said, even though the government isn't going to do a mandate, that they may be inevitably involved, even if just transactionally. So there's currently 17, at the time of this meeting, which I think was in May, there are 17 organizations that are putting forth these different vaccine passport credential initiatives. And I think it just shows another form of techno-solutionism that's being proposed, and that the government is saying that they're not going to do it, but then they're hosting this kind of event and saying that they need to have this unified response, just kind of shows how they want to avoid like the political aspect of it, but that it still serves their goals of empire, and letting it be done by private organizations kind of allows them to not be involved like politically. But this vaccine passport effort is still a part of our economic health, and getting us back to normal as soon as possible. And I think someone's question about public health being used for like scare tactics, I think something that I've been more concerned with is public health being used to make it seem like everything's fine, to ensure that our economy is still functioning, that people still have faith in the economy and the global markets, and so I think that these vaccine passports really relate to that effort and the focus of public health, to make sure that everything gets back to normal as soon as possible, not to end the death and the disparities, but to ensure that our economy is still functioning. And I think that also gets to the root of why this techno-solutionism is not the answer, because this isn't stopping the death and the disparities that we're seeing in COVID-19. And if we wanted to do that, then we would be focusing energies in other places. So yeah, here's these 17 different organizations. I wish I knew what was said in this meeting, but yeah, that's kind of the gist of that.
Great. Well, that's that opens up a whole lot of questions, and just inquiring minds want to know. So, folks, anybody has any? We've opened up the unmuted stuff. So please feel free to, if you have any question or any comments. Anybody? Because well, while we wait for other folks to have a question, I think I don't want to again take too much space either, but the question comes in that in this research or search that you all were doing, and Consuela and Brianne, around Palantir and data sharing. I mean, obviously Palantir is a major data processing corporation, and it has its hands in just into everything from financial institutions to public sector, into government, into law enforcement, into Department of Defense, into the foreign services, into international relationships. I mean, they are just all over. They're literally a global sort of a data processing system. So how do you see that? Like, what are, and given the nature of public health, and given that how personal it is, and how private it can be in a sense, how do you see the harm, and where, because that's what we have been looking to map in the stalker state, that just maybe how do you see that expanding?
I think it's already almost already being shown. I know that Palantir had I think a contract with, I think it's HHS, that was kind of working, I think, in partnership with ICE. And I think there was a huge worry in regards to that information being used as like a deportation tactic, that you could identify individuals. And so I think in and of itself, that I think just like screams the harm that can come from something such as this, but also it really takes away the autonomy that individuals have in regards to their information, right? You think that you're going to the doctors, or like, you're going to the hospital to like get some care for something, but your information is being used elsewhere, really without your consent. And I think that also plays into these fears and like completely and totally legitimate worries that people have in regards to healthcare, right? That like they're just, these systems are just finding another way to like marginalize individuals that are already extremely apprehensive about using a system that is not for them, And so there's so many systems at play that it's almost hard to keep track, right? That like COVID has really really shown that everything that happens, not with just within the nation, but internationally, is not for individuals that look like me, right? And so, yeah, it's really shown that like, what is autonomy even? Like, how much power do you have over your own information? And then what is it being used for thereafter? So it just perpetuates these very like racialized systems and shows that racism really just creates a new face every like, a couple generations, right? It just looks like something else. And so this just may be another way that it looks.
So there's a follow-up question there, Consuela, that you reviewed Palantir contracts, and but you looked at the Department of Defense and looked at Homeland Security and Department of Justice, or just all across, maybe kind of looking at the whole landscape in relationship to COVID.
Just to clarify, the question is, did we only look at Palantir?
Looking at Palantir, did it cut across a whole lot of different, agencies which
Oh yeah, they got their toes everywhere. Okay,
right.
Like there's like one toe in like each like little like bowl. They're just like, and it's so crazy that they are everywhere. Like it's almost as if like they're like like on their website, it just says, let me read it to you. I had it pulled up. It says that public health agencies around the world are using Palantir to create national common operating pictures to drive their responses. Palantir lets each agency create a unified catalog of data to power responses workflow. So that can look like tracking and analyzing the spread of COVID, measuring effectiveness of mitigation strategies, coordinating local institutions. And so that in and of itself speaks to how many like different bowls they got their toes in, but they're everywhere doing almost everything. And so I think that is what also like speaks to the alarm or like the concern that like people are having in regards to like the contracts that they have and how vague the contracts are. Like there are, Britt and I have been looking for like what, months now? Like you can find nothing in regards to like the specifics of their contracts with government agencies. Nowhere.
I can share just to explain the scope of this. This is from the US spending website. And these are all Palantir contracts. I need to move this. And these are all the different awarding agencies. So they have Department of Defense, Department of Justice, Homeland Security, Securities and Exchange Commission. So these are all different contracts that have been awarded to Palantir through different government agencies. And I think there's been like over 42 million just COVID alone.
That's a whole lot. So like the whole alphabet soup in there is very much there. There was this one question. I'm just going back to the comment, and I think what they were saying, like it was something to the extent about like, what about immunity passports? So so I know that this is a political question as well, but does anyone, if you want to comment on that, about your views about, or just where we are headed with immunity passports and data processing and Palantir gathering everything and about us?
I think what Consuela said about autonomy is really important here around the conversation on immunity passports. I mean, someone who I know that like Jamie and Hamid, you all have kept your eye on, Scott Gottlieb, right? American Enterprise, like board member of Pfizer, former commissioner of the FDA, right? Like, wrote that key article for the Wall Street Journal about how science says everyone should take off their masks now, CDC, get on board. You know what I mean? Like, this person made the argument that like immunity passports are for the individual to get access to their data and be able to use their data for access, right? So then you think about how, getting back to like taking like a more macro look at things, like access has always been like a gateway into then restricting access, right? Like, and so this is both simultaneously going to let us know who can move, and then it start to work out the kinks of who should not be able to move. And whether it's climate, right, or stealing people's homes right now in the middle of a pandemic, not letting people reclaim the homes that you've already stolen, right? Like all these things that are putting people into mass movement and migration around the world, right? Like 79 million people are like on the move since 2019, right? Like what is the significance of this concept of immunity passports and determining who has access to place and space in the context of so much movement of people, right? Like, and so I think that on the one hand, while it brings up like things that I know the coalition's like always got their eye on, that conversations of privacy are like should always be like a trigger that something's going in that shouldn't, right? Or like and like these are things that like you need to pay more attention to, which I think what Mina is bringing up about the HIPAA, it becomes really relevant here. And I love later on for like Shakir, if there's time to get his like expertise to, if we can send him this stuff, I think he'd be really great to weigh in on the changing of the HIPAA language and what that means and where you see this traditionally. That conversations of the privacy and autonomy make people feel like they have to fight for something, and that very thing that they're fighting for is then used and weaponized, right, to like restrict and control other people in these very specific ways. So I think that immunity passports, on the one hand, it's about, as Brianna is saying, the public-private partnerships to pilot it, because the federal government and the WHO are not going to endorse or support it. And in fact, they're telling people, don't get worried, we're never going to do that, right? But they have said, hey, states, do what you want. So for example, I know somebody who's traveling to Hawaii who's talked about how they all have to get COVID testing, right, and have their results before they come into Hawaii. They're each having to pay like something ridiculous, like over $100 for each, to get tested to be able to go. And so right now it's like, no, like that should be like my county COVID test should be able to get me access to go in Hawaii so I don't have to spend this money. Like that battle and that fight for that will have like implications for so many people, and specifically Black and brown and poor communities, in ways that like, I know that we can kind of see, but we still won't know until it goes live, right? The extent of it. But if, like, as people are pointing out here, public health can, be used to like make people like, to scare people into action or to give people comfort into action, right? Like the way that it can be moved in these ways. This is one of those situations where we have to like look at it a lot more soberly.
So somebody
think
just,
also,
yeah, go ahead, Brianna.
I was just going to say that also, like, just any type of policing people is always disproportionately going to impact Black and brown people. And, vaccine passports aren't a new thing, but my research found that early in like the late 1800s, there was a vaccine for plague, and they started using vaccine passports. And one of the first times that they were using it was for Hindu and Muslim pilgrimages. And so it's like, when are we going to demand vaccine passports and the context in which that's going to happen? And we know just from all other types of policing that it's always going to disproportionately burden certain groups. And also just with the lack of access in certain areas to vaccines. And even once there is increased supply and access, like that there may still be lower vaccine uptake in certain groups, that it's ultimately going to continue to reproduce these disparities at the cost of, other privileged folks being able to go to the Hollywood Bowl, So yeah, I think that's an important aspect of why these vaccine passports have a significance as well.
Yeah, I'm posting this in chat for everyone. So Steve just posted this, so it just came to me, but like this is happening in Orange County. This happened today, where, they are, so they voted they're canceling the coronavirus vaccine records. Basically, that's what this whole thing was. That they had this meeting today, the Orange County supervisors, and they voted to stop looking into providing people with digital proof of coronavirus vaccinations. So yeah, I mean, I think it's interesting that just how the various kind of movements sometimes converge as well on some issues with different kind of reasons. But there's so in a sense, how does that then impact? Because obviously, just as working towards as data abolitionists, like for us, this is going back to what Jamie just said, that how much data do we really need? But then how does one respond to? And I'm just going to play devil's advocate here for a second, in the sense where in the context of the public health landscape. About not having records available, and so how do we identify that? So what would be the response to that?
The profession is based on like one of its essential services is that it's going to assess and monitor your health, and so that it needs this information to make decisions. To know what to do around boosters is going to require some level and degree of genomic surveillance, right? And I think like we have to come to terms with how we manage the health of people and populations, includes workers, right? Like, just how we manage them is completely dependent on data. Now, can we reconceptualize a different way of providing care of course, can we do it on the level and scale of which like a nation or a county or whatever, right? Like how we've organized ourselves politically, right? Can we do it on that way? Like that's an important question. I think that has to be answered. So, but if we see no other way out of it, then like we can't get into the trap of like, does public health need data or not? We have to, I think, step back to who is public health to the state? Because if they need to do that, right? If the doctor needs to know, for example, that when you're leaving an incarcerated facility, like what your HIV medication status was, so that they can keep continuity in your care, so that they then are saying, no, I need access to your medical record that you had like in this other department of this place, because I can't do my work. Like if we think that that's valuable, then we have to go even more upstream with it. I don't think data, the conversation on the role of data to these sciences is far enough into it, because it's too much of the ship is too big, because of how connected we've allowed for it to become and integrated into our life. The exciting thing is, of course, all the mutual aid work, not given the appropriate amount of attention in the pandemic, are like, are decolonizing ways of addressing, right? Like, vaccine and disease management, right? Like, other like practices, whether we call them alternative, complementary, indigenous, like, right, taking a healing justice framework didn't happen, right? To our understanding of how to come out of like COVID. And that's important, but I don't think I cannot see us being able to do this work without data. I can't. That's just, the way that it is right now.
Right. Until we get to a certain point. Jamie, were you going to make a comment to that?
Yeah, no, and part of what I was thinking, what I've been thinking too, is that we also like, that's why that the controversy around vaccine passport ends up not like kind of answering any kind of question, or doesn't have a solution, because it's not the crux of the problem. Now, if we go, okay, no vaccination passports, and everybody gets on board, and there's this one big happy umbrella that everybody's sitting under, but then we start saying, okay, well, let's start talking about the real solutions, which we need housing. We need to like look at our medical system and how it's actually like centering the hospital too much. We need to take away money from surgeries and start, looking at primary care, start, addressing, people's comorbidities. We need to start, addressing their access to food, their access to, schools, and we need to start doing that. All of a sudden, that nice little umbrella where you think like everybody's on board for these various reasons really just has a bunch of holes in it, because those people are against immunization passports because there's American exceptionalism about my right to travel, my right to do, my right to consume, my right to be wherever I want to be at any time, and the government's not going to restrict it. But then if we start and if we stay stuck in that conversation and we all get on board and we all start breaking that down, we're missing, and I think I agree with what Pita is saying, is upstream, which is where the real battles are at. Because that's what we need to be talking about, because that will resolve a pandemic. But if not, we're just in perpetual pandemic mode, and we're constantly, some communities are dying because variants are coming and there's an outbreak. And so now we are able to geolocate where these people are at. Who knows, when we think about containing and controlling and the ability to kind of keep, and these are the things about these surveillance systems, these data collection systems, these data processing systems, these mapping systems, is they're not perfect yet, but the goal is to get perfect. And so now COVID has just given them a reason to accelerate what they're doing. And so they're like, and that was the beginning of this whole thing. How are natural disasters giving agency and incentivizing private and state, corporations to kind of implement what they've always wanted to implement, which benefits the status quo, which benefits how the system is operating and helps them maintain the system that's operating. Now, does that mean that we don't participate in any of these technological solutions and that we try to, in some sense, run a purist mode? I don't think that's the answer. It's not the answer for me, because I'm what I consider a freedom fighter. So I need to do everything I can to keep myself alive, to keep asking these questions, to keep pushing these things, because they will make the situation intolerable for you to survive. So then you start asking, the diabetic who doesn't have access to food or to the ability to go out for walks, or, well, you're going to deal without insulin because it's type 2 and we're just going to handle it this way. But there are so many type 2 diabetics that don't have access to anything, that they need to take their insulin to maintain life and health and keep living, to keep fighting. So and that's the piece where I feel like we have to be able to hold those contradictions. And if we're not holding those contradictions, then we're not going to be able to resolve the larger problems and stay alive to resolve those problems, because the state is doing everything possible to not only keep these systems tracking us, but to make sure that some of us die in the process. And we saw in that map that I showed that the people who are dying are people who are in South Central. There are people who are on the East Side, the people that are in San Fernando. Those are the people that were dying.
I'd be interested in seeing kind of an added layer to that map is something that Dr. Amani is always talking about and reminding us of the collateral consequences of the pandemic, so the social and economic consequences of it, implications of it, and how, a lot of these inequities will be, deepened or exacerbated as a result of it. So it would be curious to know who's reporting on that, to see on a wide range of social and economic indicators, how certain neighborhoods have been, how these inequalities have been even deepened as a result of the pandemic. So it's not, because it's not just
what's interesting about
cases and deaths, right? But it's thinking about housing, employment, educational outcomes, so many other things that we know are critical for sustaining community health and well-being.
Thank you.
Yeah, I was just thinking about that real quick. If I can just say one more thing, Hamid, is that even when we think about India, right, the biggest sensationalization that's coming out of there is that so many people are dying, the hospitals are abandoning patients, and that's a huge tragedy. That's nothing to be missed. But then again, when we start looking at collateral damage, so many generic drugs come out of India, right? So many poor people are dependent on generic drugs. Other vaccines that are fighting other epidemics that we've had are coming out of India. So we have not even started to see what the results of their devastation, how that's going to reverberate. And today I was just thinking of how the chicks come home to roost, and and how even at the police commission, more speaking about how we're ending this pandemic is almost coming to an end, and I was just like, why are you lying to people? Like, why are you lying to people?
Thank you. No, that's definitely. I thought I saw Gloria unmute, and then did you have a question? Oh, I guess they were heading out. Well, this has been a very instructive, and thank you for the depth of the conversation. And and what I was going to propose to you all is, and to us all, that if this team is down to, it'll be really very helpful as we go into this mode, into where we are. That if we can invite you at least maybe once every 2 or 3 months to hold this conversation and share where things are, because it is really critical. That's given the ecological disaster and given the ravages that are going on, pandemics are there. So it's not, this is not the only pandemic. There's way more to happen. So we would love to really have you all back, and just see. Oh, so Gloria, you're back. Gloria, did you have a question or something? Because I've noticed
No,
that.
no, it's really good to see you all. I was just like, let me see if they're still on, and I could just hop on and see you all for a little bit.
Welcome, Gloria. Happy to hear your voice. So yeah, we're actually going to be wrapping it up. So with that, I just want to thank you all very much for making the time for this really critical conversation, and would love to have you back. And just this thing is going to be uploaded by Saturday, and next Tuesday is our webinar on war on youth. There's a lot going on, and particularly particularly the way things are happening in Jerusalem, and this whole impact on Palestinian youth in the United States, and the way now they're coming back with more expanded and heightened just process of just impacting the youth. So I just saw a message. We're gonna wrap this up. I'm gonna stop the recording, but I think if folks have anything else that they want to just